Torsades de pointes, a French term meaning twisting of the points, is a life-threatening type of ventricular tachycardia, or rapid heartbeat, characterized by a distinctive twisting pattern on an electrocardiogram, or ECG. This cardiac arrhythmia can lead to sudden cardiac arrest and death if not promptly recognized and treated. Understanding torsades is crucial for healthcare professionals and anyone interested in cardiac health. The most common cause of torsades de pointes is drug-induced QT prolongation. Numerous medications, including certain antiarrhythmics, antibiotics, antipsychotics, and antihistamines, can prolong the QT interval, making the heart more susceptible to this arrhythmia. Electrolyte imbalances, such as hypokalemia, hypomagnesemia, and hypocalcemia, can also increase the risk. Less frequently, congenital long QT syndromes, genetic conditions that affect the heart's electrical system, are responsible. Other contributing factors may include bradycardia, or a slow heart rate, and underlying heart conditions. Torsades de pointes arises from abnormal repolarization of the ventricles, the heart's lower chambers. Prolongation of the QT interval reflects delayed repolarization, creating a vulnerable period where the heart is susceptible to early after depolarizations, or EADs. These EADs can trigger ventricular arrhythmias, particularly when combined with other risk factors. The twisting appearance on the ECG results from the changing polarity of the QRS complexes around the isoelectric baseline, reflecting the unstable and rapidly changing electrical activity within the ventricles. The abnormal ion channel currents, specifically related to potassium, sodium, and calcium, play a significant role in disrupting the normal cardiac rhythm. Torsades de pointes is a relatively uncommon arrhythmia, but its incidence varies depending on the population and the presence of predisposing factors. It's more frequently observed in patients taking QT, prolonging medications, particularly when combined with electrolyte imbalances or other risk factors. Individuals with congenital long QT syndrome have a higher lifetime risk of developing torsades. Accurate epidemiological data is difficult to obtain due to the transient and often underdiagnosed nature of the arrhythmia. Symptoms of torsades de pointes can range from mild to severe. Some individuals may experience palpitations, dizziness, or lightheadedness. Others may present with syncope or fainting due to the reduced blood flow to the brain caused by the rapid heartbeat. In its most severe form, torsades can degenerate into ventricular fibrillation, leading to sudden cardiac arrest and loss of consciousness. It's important to note that some patients may be asymptomatic, and the arrhythmia may only be detected during routine ECG monitoring. Diagnosis of torsades de pointes primarily relies on a 12-lead electrocardiogram, or ECG. The ECG will reveal the characteristic twisting pattern of the QRS complexes around the isoelectric baseline, along with QT interval prolongation. It's also important to assess the patient's medical history, medication list, and electrolyte levels to identify potential causes and risk factors. Continuous cardiac monitoring is often necessary to capture the transient episodes of torsades and to assess the effectiveness of treatment. While there aren't distinct types of torsades de pointes in the same way we classify other arrhythmias, it is useful to consider the underlying cause as a way to manage treatment. Drug-induced torsades may require different management strategies compared to torsades caused by congenital long QT syndrome. Identifying the specific cause is important because some congenital long QT syndromes respond better to certain treatment over others, and can even have some treatments worsen the symptoms. Similarly, the rate and appearance of torsades can vary depending on what medications are inducing it. The immediate treatment for torsades de pointes is aimed at restoring a stable heart rhythm and preventing cardiac arrest. Intravenous magnesium sulfate is the first-line treatment for most cases, even in the absence of hypomagnesemia. Correcting any electrolyte imbalances, such as hypokalemia or hypocalcemia, is also crucial. If the arrhythmia persists, temporary pacing or electrical cardioversion may be necessary. For drug-induced torsades, the offending medication should be discontinued immediately. In patients with congenital long QT syndrome, beta blockers and implantable cardioverter defibrillators, or ICDs, may be considered for long-term management. Prevention of torsades de pointes involves identifying and mitigating risk factors. Healthcare providers should carefully assess patients' medication lists for QT, prolonging drugs, and consider alternative options when possible. Electrolyte levels should be monitored and corrected as needed. Patients with congenital long QT syndrome should adhere to their prescribed medications and lifestyle modifications to minimize the risk of arrhythmias. Routine ECG monitoring may be warranted in individuals at high risk. The prognosis for torsades de pointes depends on the underlying cause, the promptness of treatment, and the presence of other medical conditions. Drug-induced torsades often resolves completely after the offending medication is discontinued and risk factors are addressed. Patients with congenital long QT syndrome require ongoing management to prevent recurrent episodes. Recent research has focused on identifying novel genetic mutations associated with long QT syndrome and developing targeted therapies to correct the underlying electrical abnormalities. Furthermore, research continues to identify new medications with QT prolonging effects, raising awareness among prescribers and pharmacists.